The inflammatory response is mediated by locally released inflammatory mediators. So we know that when the tissue is insulted, there's going to be an inflammatory response. And we also know that the tissue insult can be a wide variety of things, like trauma, or heat, or cold, or radiation, or infection, or an immunological insult. But whatever the cause of the inflammation, we know the response is the same. And whatever the cause of the inflammation, the actual inflammation is mediated locally via pro-inflammatory mediators. Groups of proteins and chemicals that stimulate and choreograph the inflammatory response. It should be a well-controlled process. And I want to look at three types of inflammatory mediator. The first one is the prostaglandin type of mediator. The next one are locally released vasoactive chemicals. And the third group of pro-inflammatory mediators I want to look at are cytokines. So let's begin with the prostaglandin type of mediators. Now we know that cells in the tissues contain phospholipid cell membranes. And as we've noticed before, the membrane structure is significant inside the cell as well as round about the outside of the cell, the endoplasmic reticulum, for example. So cells contain phospholipids in their cell membranes, phospholipid cell membranes. And when a cell is damaged, when there's an insult to a cell, that cell can be killed or it could be injured. Now this means that phospholipids that should be in the cell membranes are now released into the tissue spaces. So when there's an insult to the tissue, cells are damaged and we're going to get phospholipids released into the tissue spaces. So we've now got free phospholipids in the tissue spaces. Now, in tissue fluids, there are enzymes which are tissue-based enzymes. And hanging around in the tissues, there is an enzyme called phospholipase. Phospholipase type A. So phospholipase A is an enzyme, and it's just kind of hanging out in the tissues waiting for something to do. But when the phospholipids appear from the damaged cell membranes as a result of the tissue insult, the phospholipase A will actually act on these phospholipids. And what they will do, the action of the phospholipase A on the phospholipids will convert them into another substance called arachidonic acid. Arachidonic acid. Now, very often in science, new substances are named by where they were discovered. And you can see from this name that arachidonic acid was discovered in arachnoids, which of course are spiders. But in humans it's the same, so it's arachidonic acid. So the phospholipids from the damaged cell membranes, under the influence of phospholipase A, is converted into arachidonic acid. So this means we now have arachidonic acid in the tissues. That's fine. Now there's another enzyme kicking around in the tissues called cyclooxygenase. So cyclooxygenase, sometimes just called COX. Cyclooxygenase enzyme, again, is hanging around in the tissue fluids. But then when there's some arachidonic acid around, the cyclooxygenase will convert this arachidonic acid. The cyclooxygenase will enzymically act on the arachidonic acid and it will convert it into prostaglandins. So now we have free prostaglandins in the tissues. And it's the prostaglandins which are the inflammatory mediators. So the prostaglandins will bring about the inflammation. The inflammatory response is mediated by the prostaglandins. So, damaged cell membranes. Cell membranes are made of phospholipids. That means we get free phospholipids. Those free phospholipids, now in the tissue spaces, are acted on by the tissue enzyme phospholipase A. That converts them into arachidonic acid. Cyclooxygenase, another tissue-based enzyme, converts the arachidonic acid into prostaglandins, and the prostaglandins are the inflammatory mediators, bringing about the inflammatory response. So why have I put you through all this chemical difficulty? Well, it's interesting, of course, to know how the inflammatory process develops, but also this is very important for our pharmacology. Now, we've already established that inflammation is a very useful, no, it's an essential mechanism. It is the first stage in the healing process. So we need inflammation. It's absolutely essential. But in the clinical situation, you'll come across patients for whom the inflammatory response is doing more harm than good. Now, this is a difficult clinical decision because usually inflammation is good. And if we suppress inflammation, that has deleterious consequences for our patients. So normally we don't want to inhibit the inflammatory response because we know it's the first stage of the healing process. But there are other times where the inflammatory response itself can become destructive. For example, in autoimmune diseases, there can be autoimmune attack and inflammation on the body's own tissues. Sometimes we need to give anti-inflammatory drugs to inhibit this autoimmune response. Or the patient might have inhaled hot gases and their airways might be becoming edematous, and the edematous airways could actually close off the airways, resulting in asphyxia, which takes us back to our ABC priority, because if something's interfering with A, that's going to take priority. It's interfering with airway. So clinically, there's going to be situations where we need to suppress the inflammatory response. And we have a group of absolutely superbly powerful anti-inflammatory drugs. And these, of course, are the steroid-based drugs. So hydrocortisone or prednisolone or methylprednisolone. All of these are anti-inflammatory drugs. So if you give someone some intravenous hydrocortisone, you are going to almost abolish the inflammatory response. You hardly get any inflammation at all. And one of the main mechanisms by which steroids work, hydrocortisone works like this, prednisolone works like this, is they inhibit the activity of phospholipase A. So giving steroids is going to inhibit the activity of phospholipase A. That means that there can still be tissue insults. It also means that the phospholipids will still be released into the tissue spaces. But now there's no phospholipase A to convert the phospholipids into arachidonic acid. Therefore, you're not going to get the arachidonic acid. Therefore, it can't carry on to be converted into prostaglandins. Therefore, we're not going to get the inflammatory mediators. That's why steroids have such a potent anti-inflammatory effect. Sometimes very useful, sometimes completely life-saving. So steroids are anti-inflammatory drugs. But there's another group of anti-inflammatory drugs, and we call these the non-steroidal anti-inflammatory drugs, the NSAIDs. So drugs like indomethacin, ibuprofen, diclofenac, these are non-steroidal anti-inflammatory drugs. Aspirin is a non-steroidal anti-inflammatory drug. Now these drugs are anti-inflammatory, it's true, but when you take one in the initial instance, actually the main mechanism of action is that it's analgesic. But if you keep giving it for 24, 48 hours, you will get some anti-inflammatory effect. And all of these drugs work in the same way. they all work by inhibiting the action of cyclooxygenase. They reduce the activity of cyclooxygenase. So when you give a non-steroidal anti-inflammatory drug, the phospholipids can still be converted to arachidonic acid, but less arachidonic acid is going to be converted into prostaglandin, so you're going to have a reduced anti-inflammatory effect. So steroids working at the level of the phospholipase A, and cyclooxygenase being inhibited by the non-steroidal anti-inflammatory drugs. Let's look at locally released vasoactive chemicals now. Now actually, inflammation is a complex process, and inflammatory mediators can actually be derived from the plasma, because when the tissue is damaged, capillaries can be damaged and plasma can leak out into the tissue spaces. So some locally acting pro-inflammatory mediators are derived from plasma. And likewise, when there's injury, platelets can aggregate around the site of injury, or platelets can leak into the tissue spaces. So platelets also contain some pro-inflammatory mediators. And if there's injury to a tissue, the endothelial cells comprising the walls of the capillaries and the small blood vessels can also be injured, and they can release locally acting pro-inflammatory mediators as well. And we've also looked in other videos at complement, the complement system. Complement can act as an inflammatory mediator also. So actually there's quite a few pro-inflammatory chemicals released from tissues locally when tissues are injured. But one of the classic ones that everyone knows about, or most people know about, are those released from mast cells, particularly histamine. So here we have a blood vessel, the endothelial cells, and we have, as we know, inner tissue cells. So here's some normal tissue cells. So we have the capillary taking blood to the tissue cells, which is good. But also in tissues, especially the skin and the mucous membranes, there's a group of cells called mast cells. These derive from basophils in the blood. So basophils will migrate into the tissues. Normally, this is normal. And the basophils, once they're in the tissue, that becomes a mast cell. And the mast cells contain very large granules in their cytoplasm. And these vesicles, I've called them granules, they have a granular appearance under the microscope. They're actually vesicles, vesicles being a membrane-bound area inside a cell that contains a fluid. And the fluid inside the vesicles in the mast cells contains histamine. Then when there's an inflammatory insult, especially if that inflammatory insult is caused by parasitic infection, or if it's caused by an allergen, by an allergic type reaction, especially in those circumstances. It works in other circumstances as well, but mast cells come into play particularly in those circumstances. Then the histamine is going to be released. The cell actually kind of breaks open. The cytoplasm just breaks open. The cell membrane breaks open. And these vesicles of histamine are released into the tissue spaces, releasing histamine into the tissue spaces. And of course the histamine will act on the blood vessels, causing the vasodilation, which is so characteristic of the inflammatory response. So tissue-based mast cells. And actually it's amazing, the mast cells can break right open, let all these granules out, but then the membranes can seal again and the mast cell will completely recover after discharging large amounts of histamine into the local tissue fluids, bringing about this local vasodilatory response. So, locally active vasoactive mediators released from platelets, from plasma, from endothelium, vascular endothelium, via complement, and as we see here, via histamine. Now, the third group I want to talk about are the cytokines. The cytokines. Cyto means cell, and kine is from the Greek word kainos, it means movement. So cytokines are actually proteins released from one cell that will affect other cells. And they are low molecular weight proteins, they are short chains of amino acids, the cytokines. So released from one cell but affecting other cells. And actually we now know that cytokines are released from a very large from many different types of cells, from a large variety of cell types. But the coordinating cytokines that you're interested in for the inflammatory response are mostly released from macrophages and to some extent from lymphocytes. Macrophages, for example, release a very potent pro-inflammatory mediator called tumor necrosis factor. Tumor necrosis factor, TNF. Now again, I know it's called tumor factor, but we're not talking about tumours here, are we? Well, again, this reflects where it was discovered. It was discovered in the study of oncology and tumours. So TNF, tumor necrosis factor, released from macrophages. And other cytokines are released from macrophages. So here we have our macrophage in the tissues. It's detecting the presence of the tissue insult and it's releasing cytokines. And these cytokines are going to have local effects. But as well as that, there can be systemic absorption of the cytokines. But I think we'll do that in a minute. But let's look at one more effect of the cytokines first of all. The cytokines, particularly those released from the macrophages, will actually attract the neutrophils. So studies have been done particularly in venules of inflamed tissue, and what you find is that lots of neutrophils start marginalizing. They come to the edge of the vessel, and of course that puts them in a good place to migrate through into the tissue spaces where they can be phagocytic, which of course is very useful. And the local released chemicals will cause vasodilation, we know that. But what we didn't mention on the previous talk was that they can actually cause constriction of the endothelial cells. So the endothelial cells can actually crumple up and become smaller. So here we see a more crumpled up, constricted endothelial cell. It's kind of crunched up on itself. There's different views on how it happens, but it definitely happens. And I think you can see if we've got two crunched up cells now, if we look at that, instead of having a little gap between the individual endothelial cells, we've now got a big gap, which obviously is going to increase capillary permeability, allowing the formation of useful inflammatory exudate. Now, I started to say before that the cytokines are also released into the blood, and that's true. So cytokines can also have a systemic effect. They can be released into the blood and go all over the body. For example, cytokines from macrophages can go to the bone marrow and stimulate the release of more of these very useful granulocytic polymorphonuclear neutrophils, which of course is great because we want them here, and this can actually stimulate the release of more from the factory, which is the bone marrow. So there can be systemic effects. But basically, if we've got a small area of inflammation, we're going to get a small localized area of inflammation. But if you've got a big area of inflammation, for example, if you've got a significant injury, or if you've got a lobe of a lung which is infected with pneumonia, or you've got a cellulitis, or a pyelonephritis, or some other significant cause of inflammation, can you see, instead of having a little area of inflammation, this means we're going to have a great big area of inflammation. If you've got pneumonia, if you've got bronchopneumonia, you can have like inflammation over both lung fields. You've got a colossal organ which is inflamed. And that means you're going to get the release of lots of inflammatory mediators. Lots of cytokines are going to be released into the blood. And you're going to get systemic absorption of pro-inflammatory mediators, systemic absorption of cytokines. They're going to be all over the place. And this will bring about what is called an acute phase response. So if there's a lot of inflamed tissue, we're going to get systemic manifestations of inflammation. And in fact, this is called an acute phase response. Sometimes it's called a systemic inflammatory response syndrome, a SIRS, a systemic inflammatory response syndrome. An acute phase response, where the inflammatory process has ceased to become local and has become systemic, affecting all of the body. And that's what we want to look at in the next section.